Awaiting your results. How are you doing?
Thank you, Michael. And by the way, before we get to that, we're past the point of easy answers here, and you are having the necessary hard conversations. I've been listening to your programming while waiting to talk to you. Good job, and I thank you for that. Yeah, I'm still awaiting test results. They're taking far too long. I assume I have it. I've got all the symptoms of this infection in the middle of a pandemic, so it's a case of it flaps like a duck, it quacks like a duck. But for public health purposes, we need a much faster turnaround so we know what's going on in the population. So my wait is disturbing me, not so much about me, because I know what to do in the meantime, but it's disturbing me about what it means for our ability to respond to what's going on nationally.
We wish you good things with regard to your health.
Thank you.
I should also tell the audience, this is a pretty sophisticated audience. You are the guy, you're the physician that Tom Friedman has been relying on to a great extent. I want to put on the screen something that you wrote this week. Quote, I think authorities could align and announce now a commitment to both immediate interdiction efforts that are ongoing and data analysis. That data analysis will inform a major public update on or by some day, a week or two or three. It would give people a lot of hope to know there are policies in the works and a proximal timeline for hearing about them that address prospects for restoring any semblance of life as we knew it before the pandemic disfigured it all. Please explain.
Well, to be clear, Michael, you mentioned the president's tweet and sort of a 180 from lock everybody down to indiscriminate largesse was never what I was talking about. Everything we do needs to be data informed, but all of the data from around the world suggests that the risk of severe coronavirus infection, hospitalization, needing a ventilator, and death is not uniform. There are massive differentials. We don't fully understand them yet in the United States, and one of the things we have to do is understand them as quickly as possible. And by the way, even as we speak this morning, I'm trying to collaborate with colleagues to connect money with boots on the ground with test kits to see if we can do representative random sampling of populations in Connecticut, in New York, other parts of the country. Who has this and doesn't know? Who has it and has mild symptoms? Who is likely to need a hospital bed? Who's likely to need a ventilator? And who is at risk of dying? If there are these massive differentials, if all the risk is mostly concentrated in elderly people, people with serious chronic disease, then all of our interdiction efforts should be concentrated there as well. That group needs more than they're getting. They need hotlines, they need services, they need people tested negative to deliver groceries to their home. They need everything we can do to keep them away from this bug. But it may be that a major portion of the population needs a whole lot less because they're massively more likely to get a fairly mild infection, recover, and become immune, which then makes them essentially part of a workforce that can service everybody. I'm hoping that's the case with me. I want to get over this thing. I want to donate blood so someone else can use the antibodies I make, and then I want to volunteer clinical services because I won't have to wear an N95 mask. I won't be able to get this. At least we hope. Another thing we need to know, when you get over this, are you reliably immune? There are anecdotal reports of people getting it twice. Is that true? Are those lab errors? All of this needs to be sorted out, and we need to be doing this right now. And one of the things we could be doing right now to comfort the public is telling them, this is what we're doing right now with data. These are the questions we're posing. These are the questions we're answering. Here's how we intend to use the answers. So stay put, social distance, shelter in place, but rest assured this is not an indefinite period. We are working on the next phase. What comfort there would be in knowing from our national leadership that's what's going on.
Dr. Katz, Bill Gates participated in a town hall here at CNN this week. Here's a short snippet of something that he said to Anderson Cooper. Roll it.
So we're entering into a tough period that if we do it right, we'll only have to do it once for 6 to 10 weeks. But we have to do it, it has to be the whole country.
What's your reaction to what you just heard?
So here's the interesting thing, Michael. When I wrote my op-ed about a more surgical strike, I wrote it 10 days before it ran in the New York Times because it had to get the attention of editors at the New York Times and then be edited and fact-checked and then rewritten and the whole thing again and again and again. When I first proposed it, I was still looking at data from abroad and thinking we could look at risk tiers and maybe shelter the most vulnerable, and that ship had already sailed. So right now, first of all, to be clear, I agree. Our only option right now is for everybody to stay away from everybody because we don't even know where the virus is. But let me explain what I was thinking. We sent young, mostly healthy adults home from college campuses in big cities all around the country because they were laid off and universities closed down. We sent them home to their parents. So, you know, these 20-somethings were sent home to 40-something, 50-something parents, many of whom have heart disease or diabetes or hypertension. And in many instances, they're multi-generational homes, so there are grandparents there too. So now we're talking about the 70-somethings who absolutely can't afford to be exposed. Did we test these kids? Of course not. Did we even take their temperature? No. That was the opportunity to say, wait a minute, deep breath. It looks like there are these major risk tiers. We may be sending people who can afford to get this and are most likely to just get over it home to infect people who can't afford to get it and who are going to overwhelm our hospital systems. So that's what I was talking about. But again, that ship has sailed. Everything moves really fast in a pandemic. Right now, I totally agree with Bill Gates. I totally agree with everyone who's saying our only immediate option is social distancing, interdiction every way we can, prevent spread, minimize the acute demands on the medical system. I don't want us to face the ethical dilemmas that Dr. Kaplan was talking about. I totally agree we have to prepare for them, but I don't want us to find ourselves there. But then let us do the data analysis right now. And again, I'm working on it. I hope many others are as well. The public deserves to hear about it, to answer questions about risk tiers and see, can we in fact do a better job allocating more resources to protect those who really can least afford to get this thing because they're most likely to get severely sick and die? And can we invite a portion of the population back to the world earlier because they're least likely to get severe infection? And for them, this is much more like seasonal flu. And can we, into the bargain, start getting intel about herd immunity? Who has antibodies? Because people with antibodies are a valuable asset.
Dr. Katz, Godspeed. Thanks for your expertise. We wish you good health.
Thank you, Michael. Thank you for having me.
Social media. I think, Catherine, this comes from Facebook. What do we got?